Happy Friday, everybody. Welcome to yet another episode of VMR. Prof. Rez is on his way. In the meantime, we will shed light on the people who are making this happen, beginning with Sarah, who's scribing. And the mic to you, Sarah.
Hey, I'm Sarah. I'm a fourth year medical student at Emory still for a short amount of time longer.
Hours.
Yeah, just matched at University of Washington in neurology. So I'm very excited for that long across the country move and happy to be scribing today.
How do you feel about it? How does it match length for you?
Amazing. I'm super excited. There's really incredible opportunities in faculty over at UW, and um, I've never lived in Seattle, so uh, big things, big things ahead.
It's my second favorite city in the world. So yeah, I've been there two or three times now. It's absolutely gorgeous. So kudos to you. Congrats. Have you been there before, or will you? Okay, yeah, you have.
Yeah,
But how do you like Seattle?
I love it. It's an incredible city. I love like the biking culture there, which like honestly I've really appreciated about Atlanta where I am now. So excited to go somewhere else that's maybe a little bit cooler in the summer than it is here in the South. Yeah, lots of fun ahead and good hiking as well.
My
So
gosh, spectacular. Absolutely spectacular. Kevin, you're doing teaching points. Mike to you.
Hello, Robbie, and hello, Reza. I see you in the back here walking.
Oh,
Basically,
hi.
two
Hello,
hours.
Prof. Rez.
He's already here.
I'm glad someone notices my present.
Who
I
else
love
would?
I love how he's digging at me when I will make it public that at 9 o'clock he says, "Am I scheduled for today?" That's the cool life of Prof. Rez, Kevin. But
Yeah,
I you
exactly.
guys
And
are probably
also,
gonna go.
you can see the huge cap walking around in the back, and I was like, immediately there's Reza. Here he is. I'm doing very good. I'm a little nervous and excited, not because of today's session. I think today's session is going to be fun. Next week, I'm actually starting my work at the clinic
Hmm.
officially as a resident, and it's gonna be very exciting. And I will probably bring a lot of cases to you guys.
We're super. I know Prof. Rez is tempted to jump in, but I'm gonna yeah, I'm gonna keep going. Super excited for that, Kevin. That sounds really exciting. And yeah, whenever the cases that you have brought have been so rich, so excited for even more. We have a special treat though. Sam has been alluding to cases from recent rotations, and I think today is going to be a fun one. I'll hand the mic to you, Sam, to say hi.
Hi everyone, I'm Sam. Also very nearly done being a fourth year med student at Tufts. And I've just matched into emergency medicine at Maine Medical Center, and I'm so excited. Um, so yeah, just I'll keep talking about Lyme disease into perpetuity. Just so I hope you're not too sick of that yet. I have a very juicy case for you today, so I'm very excited to present and to learn from the discussion as well. I always learn a new perspective on the cases, even when people I've taken care of, just from hearing the wisdom of the CP Solvers team. So I'm so excited.
Sam, are you going to be in Maine in May? Because Prof. Rez is heading there.
For most of May, yes.
Okay.
At the end of May, I'm going on a trip, but
He's like,
I
definitely not, especially the moments that Prop Rez is there.
Not at all.
it burns my vacation.
Prof. Rez, we need to hear your beautiful voice. Mike to you, my friend.
All right. Are we ready to get the case going?
Wow, so formal. Tell us what's up. These guys haven't seen you for a month.
Well, here's I don't know. Oh, let me turn down let me turn around the camera. Well, I know it's a little blurry in the back, but it's my usual morning day walk to work. It's through Veterans Park. Robbie, there's a soccer field right there. I don't know if you can see, it's pretty blurred. But it's always so nice, like trees, flowers, squirrels. It was a great day until I got that text from you that it's time to rock and roll.
All right, let's do it.
Let me ask you a question. Why are you dressed so formally these
I gotta
days?
go. Oh, this is athletic wear, Prof. Rez. Don't let the formality fool you. You know I don't dress formal, but I have a day ahead of me, Prof. Rez. I'm working from 10:30 to midnight, 10:30 a.m. to midnight. So
Wow.
yeah, it's gonna be a stretch. So I'm ready. I got my food packed. Um, yeah, so I gotta go to work right after.
Man, best of luck today, my man.
Thank you, good sir. All right, let's do this. Mike to you.
All right, I'm gonna share my screen first before Sarah puts up the board because I'm gonna give you the chief concern in visual format today. So here's a photo of the patient's left lower extremity. If you want to get a good look at that. And then this is where we sort of lifted his leg up off the bed and took a photo from um sort of the back of the leg. So this is our
Ooh.
presenting concern. Do you want me to keep this up or do you want me to switch to the whiteboard?
Damn, totally your call, but I can start speaking about this. Let me make sure I got the camera facing my face. Rob, is it facing my face right now or the street?
It's the street now. Yeah, it was
Okay,
perfect.
one
There you go.
second.
Yeah. All right, you're good now. Oh,
I'm gonna, okay.
now you're not.
Oh, one second.
All right, good now.
Do you know that one commercial? I don't know which wireless network it is. Like, can you hear me now? They're like, no. Can you hear me now? Can you hear me? But okay, so I'm just going to be very brief here. I'm sure that Robbie's approach to this will be way greater than mine as an emergency medicine physician. But as an internist, when I see a leg like this with a lot of ecchymoses, the thing I'm most worried about is bleeding into the skin. And so then the question becomes, why does that happen? Why does bleeding happen into the skin? And by the way, like we always say, you can verify that by seeing if there's any blanching, if you press down on those lesions. But I would describe these lesions as flat macular, as confluent, meaning that they're all sort of being, incorporated together, involving the entire lower extremity. So honestly, Sam, the first thing I'd want to know is there any trauma to that extremity, first and foremost? And then once I learn that detail, it will really help guide the next series of questions. Meaning, if there is no trauma, I would want to know what is happening outside of that leg. Meaning, is there any, systemic symptoms, any other extremity that may have such an ecchymotic rash? And I know you showed us the posterior calf. Like sometimes you can get ruptured Baker cyst from the posterior fossa of the knee into the calf. But to me, honestly, I just want to know, has there been trauma to this leg? Because it just looks like an extremely bruised leg.
All right, that's awesome, Prof. I got nothing to add. Yeah. Like to you, Sam.
All right. I'll give you a little more history about this gentleman. So he's 58 years old. Um, and he's presenting with rash and pain in his legs bilaterally. Um, so the photos I showed were of the left. This is actually on both legs. But it started about 6 weeks ago. Initially showed up on the dorsum of the left foot, and then it started spreading upwards. And he's describing worsening pain, swelling, and discoloration, again in both legs. And he's finding it very painful to bear weight. And he does have a history of neuropathy, but he says this feels really different than that. Otherwise, he has a negative review of systems, so he's denying fevers, chills, rigors, any dizziness, lightheadedness, chest pain, shortness of breath, or bleeding from anywhere else. He has a really interesting past medical history. So he has lupus anticoagulant syndrome, and he is on warfarin for this at home. He also has peripheral arterial disease and left-sided foot drop. So he does wear a brace on the left foot to help him keep his foot up. He also has GERD and prediabetes. We went through his records. We did find a CT scan from 5 months ago showing a suspicious appearing 1.1 centimeter pulmonary nodule. And they had recommended 3-month follow-up, which did not get done. It's been 5 months. He also has a really interesting surgical history. So 5 years prior to his current presentation, he had essentially a total aortoiliac thromboembolic occlusion that required balloon thrombectomy. This was complicated by compartment syndrome in bilateral lower extremities, requiring 2 fasciotomies in each leg. He also got abdominal compartment syndrome in the post-op course and needed a laparotomy for decompression. So that was 5 years ago. His medications, he has warfarin, oxycodone, gabapentin. He's on fenofibrate, rosuvastatin, and omeprazole. His social history, Also very interesting. He lives in a cabin in the woods, almost totally off the grid. He has no running water, and he does sometimes have electricity with a generator. His home is infested with mice, and there are ticks everywhere. For his other health behaviors, he drinks 4 to 5 alcoholic beverages daily, and he only eats a full meal once every few days. But when he does eat, he says he eats a pretty well-rounded and healthy diet, but not he's not eating much. And he also has an 80 pack year history of tobacco use. In his family history, his mom, he said, died of lupus, and his father died of lung cancer. And just big shout out to Sarah for taking on all of this.
We're making you sweat on your last day, Sarah. This is incredible. It has nothing to do with your actual rotation. Yeah, I think this is the power of Prof. Rez's framework, which he is listening to very high Prof. Rez's ears. Nice, nice to see you. Yeah, he asked two key questions to understand the nature of this disease: is it traumatic or not? And the answer is no. And is it unilateral or bilateral? And now we're trying to solve the problem of bilateral atraumatic purpura. And I think the leap that Prof. Res made is to say, hey, this purpura is so confluent and coalescing into large areas. So the mechanism of the purpura is likely ecchymosis or bleeding. Um, the word purpura, the committing to ecchymosis is really a commitment of understanding the mechanism of how the blood got there into the skin. And I think that as we move through the journey of translating this purpura into a subcategory of ecchymosis, we'll have to be open to the possibility that that translation was incorrect and that a person has a different kind of purpura. This is not going to be petechiae, it's too much, but it might be retiform. And I say that because the patient has a past medical history that suggests the possibility of retiform purpura. And what retiform purpura is fundamentally the opposite problem of ecchymosis, where the patient is thrombosing. And distinguishing the two is actually much more difficult than it would seem to be. And I made the mistake on a previous episode of going down ecchymosis when it was retiform purpura. But this really seems so confluent and so extensive that I think there's probably a 95% chance it is in fact ecchymotic. So that's just the one assumption we're making. And at first glance, the patient has very good reason to be bleeding in the skin. He's on warfarin, and perhaps owing to many reasons, including access to INR testing, nutritional issues, vitamin K, a very simple path might be that his INR is 7, and we might translate this problem to a warfarin-related coagulopathy with ecchymosis on the skin. And I think since that is such a common scenario, by far and away the most common scenario, that would be my operating hypothesis short of an emergency. And the only emergency that's present right now is to make sure that the patient doesn't have compartment syndrome in his legs. And if there is compartment syndrome in his legs, the probability, the severity of the syndrome increases, and so my diagnostic hypotheses will broaden and broaden and broaden simply because the patient's sicker. So even though we have a lot to contend with, I think the simple reasoning in my mind in this early phase of this case is this looks more like bleeding, but I've been fooled before. This could be the opposite problem, clotting. And the patient has a very good reason to be bleeding. He has warfarin on board, and warfarin interacts with medications and nutritional status very easily. So I think I saw an X at the dorsalis pedis, or no, posterior tibular artery, and presumably that X was made, which means that there is a nice, beautiful, palpable, hopefully, pulse, which means we have time. Yeah, there you go. Thank you, Sarah. Uh, and so, yeah, I would just wait for the INR and would see how this disease evolves after that heat test. What do you think, Prof. Rez?
I love that. Very excited to get more details.
All right. So our next set of data, I've got the vital signs for you. His blood pressure was 113/67. His pulse was 98. He was afebrile at 36.6 Celsius, respirations of 18, and saturating 97% on room air. On his general appearance, he was alert and oriented and in no acute distress. For his head and neck exam, he had moist mucous membranes, no scleral icterus. He had very necrotic dentition. His left lower molar was essentially rotting, and he's missing most of his teeth. Um, Cardiovascularly, normal and regular rhythm without any murmurs. His pulmonary exam was clear to auscultation throughout. His abdomen was soft, non-tender, non-distended with normal bowel sounds, and we did note his surgical scar from the lap. For his extremity exam, detailed in the photos, and we were not able to actually palpate his distal pulses, but that X does denote where we were able to get it with a Doppler. Neurologically, he has no focal deficits. For his initial labs, we got a CBC. So his white blood cell count was 5.5 with a normal diff. His hemoglobin was 8.9 and hematocrit of 26.6. Platelets are 242. His MCV is 97.7. INR was 4.2 and PTT was 49. For his metabolic panel, his sodium was 133, and we did find that that was in line essentially with his chronic sodium level. It was not an acute change. Potassium was 4.1, creatinine was 1.05, BUN was 12, chloride of 99, bicarb was 25, anion gap was 9, glucose was 99, calcium was 8.3, and magnesium was 1.9. And then we got an ESR CRP. So the CRP was 115.6, quite elevated, and ESR also elevated at 79. We got a urinalysis, which showed 3 to 10 red blood cells, 2 plus leukocyte esterase, and 10 to 50 white blood cells. We also got an X-ray of the left ankle because of the amount of pain he was having, and it showed no acute fracture, but did reveal moderate to marked osteopenia. And we got a lower extremity Doppler bilaterally, which was negative for any DVT. We did get a CT angiogram of the abdominal aorta with runoff, which showed that the aorta and the iliac arteries were patent and there was no other acute abnormality in the abdomen. We also ended up doing a lot of primary care for this gentleman kind of in the initial phase. So since he had not been able to follow up on his chest CT, we repeated that, which showed that the pulmonary nodule was now measuring 1.2 centimeters and again demonstrated the suspicious appearance with irregular margins. And then, based on what his head and neck exam looked like, we also got a CT head maxillofacial with contrast, showing extensively carious dentition with multifocal periodontal cystic changes surrounding the roots of both maxillary and mandibular teeth. And he had a periapical cyst with overlying buccal and lingual cortex disruption, but there was no organized fluid collection, no mass, and no tumor. I'll stop there. Again, thank you, Sarah. I'm giving you so much.
Sam, your presentation is just absolutely stellar, truly. One question I have for you is on that UA, was there also proteinuria?
No, there was not.
No. Okay. And the reason that I ask about that specific question is we have a gentleman who seems to be out of medical care, is quite vulnerable, having just a meal a week, who has a diagnosis of lupus and has a very strong family history of lupus. And Rabih already alluded to the link of APLS and lupus and some of these cutaneous findings that one may witness. And so I asked about proteinuria because I'm curious if the immune system is also attacking the glomerulus. In a patient like this, I would have a very low threshold to repeat the UA or do a spot protein to creatinine ratio. Because if you incorporate proteinuria with hematuria in someone with a background of lupus, then you have to be worried about lupus nephritis. And I have to say that it's not true that you need to like an hour delaying treatment will result in more nephrons being destroyed, but a day of delaying treatment would result in that phenomenon, and the goal is to protect the kidneys as much as possible. But of all the data that was presented, a few caught my eye, Rabih. I'm not really looking at the whiteboard, so I'm gonna have to rely on you to fill in the gaps. One was the hemoglobin of 8.9 with the reticulocyte count of 97. Now, the reason that caught my attention was that we know this is borderline macrocytosis. And remember, patients can have multiple processes happening at once. They can have some iron deficiency and then have another cause of macrocytosis leading them to somewhere within the normal range of MCV. But this is on the higher end. And again, we're looking at this case through the lens of someone with lupus, and we have to always be concerned for hemolysis. So in a patient like this with a slight microcytosis, hemoglobin 8.9, I would have a low threshold to work him up for hemolytic anemia, specifically with an LDH and a haptoglobin. And then my eyes would look at the ASC to see if it's more than the ALT. Now, another possibility for both the hematuria this patient's experiencing and the anemia, the hematuria may just reflect this patient being super therapeutic on the INR and being a little more vulnerable to bleeding within the glomerulus, resulting in red cells in the urine. There is this diagnostic entity known as anticoagulation nephropathy, but you never lead with that hypothesis, and it's always a diagnosis of exclusion. But that urine has really grabbed my attention. And with regard to the anemia, it could just be the amount of bleeding that this patient potentially is having within their skin. I think something else, Robbie, that really grabbed my attention was I was like, okay, it seems the branch point, and we've dealt with this multiple times now, co-discussing cases, are the skin findings blood in the skin, or is the skin findings more consistent with gangrene and tissue that's dying? And I think that was the key branch point that you were alluding to, meaning, are we dealing with microvascular thrombi leading to tissue ischemia, and that tissue ischemia leading to infarction, that infarction manifesting as darkness on the skin? Or alternatively, are we dealing with a vessel that's inflamed, leading to red blood cells extravasating, and that red blood cells extravasating leading to the pattern that we're seeing there on the skin? Now, Sam said something that was really important here. She said two things. One is that this patient's having pain. Think about all the patients you've cared for with vasculitis. If you've cared for anyone with vasculitis, their complaint isn't necessarily pain. It's not that they're having ischemia. When you hear pain, think ischemia. It's more so that the vessels are inflamed and red blood cells are leaching out. But on the other hand, if you have microvascular thrombi, now you have ischemia. And that ischemia leads to significant pain, and that pain that the patient might be experiencing. Now, vasculitis can cause pain if it involves the nerves, where you have mononeuritis multiplex. And Sam already told us that this patient also has a foot drop. The other important thing is that Sam said was that the CT with runoff didn't show any significant macrovascular disease. But I think we all know that we are at the level of the microvasculature. And then the question becomes, is it more that retiform purpura that Robbie was describing with sort of in situ vascular thrombi, or is it more vessel inflammation? I think for me, like, the pain is making me more concerned for the former than the latter. And the ESR and CRP being through the roof tells us that this patient is inflamed, is very, very inflamed. And the question becomes, why are they inflamed? That's where you have to incorporate the tempo. It's 6 weeks, so it's subacute. It's hard to imagine acute DIC manifesting as such. Like, this patient's also exposed to mice and maybe even rats, and we've had cases of DIC related to organisms to those animals. But the 6 week duration also may prioritize more of like an autoimmune phenomenon. I'm going to pass the mic to Robbie to see what he thinks. I just have to say I'm still solving the problem, and I'm using key features being the CT with runoff, the presence of pain, and looking for other findings that may suggest involvement of other organs that are common in lupus and APLS.
Yeah, Prof. Reza, I like you. I think I'm intrigued by the exact same things. What does the pain represent? What does the bleeding represent? Are those the same thing? His anemia, his coagulopathy, and I think my mind is inclined to start with what I might do next in the emergency room, which is to say, okay, you know what, his INR is high. What should I do about that? And what does that tell me? And I think what you should do about it is you have to be very careful. I wouldn't reverse his INR because he's not having any life-threatening bleeding. and he has a very, very thrombotic condition. And so I would probably just hold his warfarin for a day or two until things settle out. And then naturally, the next question after you do that is, well, why is his INR super therapeutic? And the most common reason is just inherent to the medication itself. The dosing is noisy and people can accidentally take more or whatnot. The other big thing is med-med interactions. None of those seem to be at prominent. There's no reason to think about med-med interactions in him. There's nothing that we've heard that's new. And the diagnosis of an oscillating INR without a clear reason is one, of course, that belongs at the end. So this is where the nutritional status really comes in. And you have to wonder is this patient's nutrition a variable? And when you look at that, you realize that his nutritional status is staring you in the eye. And so I think you ask yourself, why is he not intaking any vitamin K? And is that the driver for his coagulopathy? And so once that nutritional hypothesis is planted in your mind, it's hard not to unsee so many things. It's hard not to unsee the fact that his bone is also nutritionally deprived and that he has osteopenia. And you start to wonder, especially with his dentition, if there's a prominent nutritional theme here. And the only learning point that I want to pass on in real life is the notion about inflammatory markers and when they sometimes represent non-inflammatory disease. I would never assume that an ESR or CRP this high don't represent inflammatory disease until you have a pan scan that doesn't show anything dynamically sinister. Of course, he has a lung nodule, and I think that lung nodule is important. Are readily explanatory. But when you look inside the patient's body with a chest, abdomen, and pelvis, and you don't see anything that readily explains an ESR and CRP that high, I think you start to wonder whether it represents something you cannot see, like a vasculitis, as Prof. Rez said, or the very real scenario that many patients with nutritional issues are unhappy. And if you look at patients with B12 deficiency, with folate deficiency, the inflammatory milieu that these patients are in is not subtle. So where am I at? I think that there's no rush right now. The patient's stable. I would not reverse them. I'm using the INR as a potential clue for a nutritional milieu here that is enriched by the history, but also by the presence of osteopenia. And where that theme takes us, I think time will tell. Um, but I think I'm holding that in parallel with what is more acutely morbid, that the patient has a vasculitis syndrome. And for that, I think we'll have to keep an eye on the UA. And as Prof. Rez has famously said many times, you got to trend the UA. This hematuria worsens, proteinuria worsens, kidney function worsens. We have to definitely head in that direction. But if the patient's syndrome stays gentle, and there is no worsening kidney dysfunction, no hypertension, no edema, no proteinuria, then I think we'll pivot back to the nutritional status. So that's the tension I'm feeling. Is he having a vasculitic syndrome, or is this a sneaky nutritional deficiency? I think time and the pace of this disease will tell. All right, Sam, Mike, to you. What you got?
All right, incredible discussion. Thank you both so much. So I have some more labs for you. As part of his anemia workup, we got an iron panel. So his iron level was 54, TIBC was 203, transferrin was 166, and ferritin was 312. Fibrinogen was 619. We got Kirtan's favorite, an SPEP, which showed decreased albumin and increased alpha 1 and alpha 2 regions, but no monoclonal band. So this was felt to favor just a reactive process. We got a vitamin D level, which was low at 12.3. We also did the hemolysis workup. The LDH and haptoglobin and uric acid were all normal. We got a vitamin B12 level and folate level, which were normal. We got a TSH, which was normal, a rheumatoid factor, which was normal, and we got a zinc level, which was also normal. And then as part of the vasculitis workup, we did HIV and hepatitis B and hepatitis C testing. All of that was negative for infection, but he was found not to be immune to hepatitis B. So we did offer him that vaccination. And then with his dentition, we were a little concerned about endocarditis, so we got blood cultures, which fortunately were negative. We cultured the urine, which just showed normal flora and some contamination. We got cryoglobulin and cryofibrinogen, which were negative. We got an ANCA, also negative. Kappa lambda, so his kappa light chains were 4.75, lambda light chains were 3.99, both a little elevated, but the ratio was normal at 1.19. And then we called a friend, and we got a nutrition consult. And she was able to shed a lot of light on this case for us. And I just, want to, give the flowers to the people who deserve them. Our nutrition colleagues are amazing. And she kind of went way back into his history. And for a long time, his primary caloric intake has been alcohol, and only eats nutrient-dense food every 4 or 5 days. And what he told her was that up until a couple of years ago, his drink of choice was vodka with juice. So he would have 4 to 5 vodka juices per day. But a couple years ago, he switched to coffee brandy. And I'm gonna stop there.
I will I will let Prof. Rez digest this juicy history that you got and spend some time on the labs. And I think the labs are very illuminating. Um, if you're studying if you're studying this case as a rule out vasculitis case, which I think you really should at the beginning, the category of vessel that we're invoking with Prof. Rez thinking about the kidney and the skin is small vessel vasculitis. Um, as a general rule of thumb, when you compare side by side the utility of serological testing for all kinds of vasculitis, you'll see that the major investment of serology is for small vessel disease. There is no serological test for giant cell arteritis or Takayasu's, the two main large vessel vascularities. There is no real serological test for the medium vessel vascularities, polyarteritis nodosa, thromboangiitis obliterans, or Kawasaki's disease. So all this fancy spancy testing that we do, the ANCA, the complements, the ANA, the cryos, all that stuff is really for small vessel vasculitis. So while this statement is not true in general, serological testing for vasculitis is negative, rules out vasculitis, it makes a significant dent in the kind of vasculitis we're worried about here. So since we're only really worried about small vessel disease, the negative testing here is very, very helpful. There are some vascularities that don't show up on serological testing. One example is, and an example worth considering in somebody with prominent skin manifestations is IgA vasculitis. And there are negative versions of the diseases that are named by their antibody, like ANCA negative ANCA vasculitis. But the authentic answer to this case is you made a significant dent against small vasculitis because you haven't found a lab that correlates with it. So that is a huge progress towards exonerating the more dynamic disease process of a life-threatening vasculitic syndrome unfolding before us. So super helpful labs. All right, Prof. Rez, Mike to you.
Yeah, it's interesting because we had a very similar case on RLR with this sort of presentation of bilateral bruising. And I think I'm not sure if I have to revise my illness script. Like when we used to think of scurvy, we would think of these perifollicular hematomas, and you might see corkscrewed hairs, and it could mimic a vasculitis, but with the vitamin C deficiency and its involvement in the pathway of vessel wall formation can lead to bruising. And this case is just like that RLR case where the patient had a lot of nutritional uh, vulnerability and ended up being a case of vitamin C deficiency. But I think that that's great, and like for the audience to be aware of that phenomenon and that can be a diagnosis here. But like you have to be able to work your way through microvascular thrombi that might, be a presentation of APLS. You have to work your way through small vessel vasculitis while simultaneously thinking about nutritional deficiency. But yeah, I have to go and like read about this and see how often is scurvy these days presenting with these like big ecchymotic appearing lesions, as opposed to when I learned it in residency, it was like these like nice little pinpoint perifollicular hematoma. It just might be that I have to update that illness script. I don't know, Robert, did you review that anytime recently based on the last RLR episode?
Yeah, I think Prof. The phenotypic variance of scurvy is unreal. I actually have a patient on service right now, and this is potentially spoiling a future diagnosis, but I think a future fun case, but it's worth just to make an emphasis here. He was diagnosed with scurvy based on an undetectable vitamin C, and his presentation, Prof. Rez, was profound orthostasis of the autonomic type with a blunted heart rate response, with no skin manifestations whatsoever. Zero. And they thought to get a vitamin C level because a very curious, very smart, savvy medical student read about an article on orthostasis where they listed vitamin C. Without the knowledge that the skin manifestations are almost universal, and taught me something about scurvy. And the best part is the patient got better with vitamin C repletion, like the orthostatus resolved. Mark has presented a case with like subtle cutaneous findings and pulmonary hypertension. So I think all that I can share is that my real life ends are low, but enough exposure now to know that this disease is very likely the answer here for one other reason I just to shed light on, has so much flexibility. But the reason it was triggered in me reflexively, Prof. Rez, is something that you emphasize, which is pain. Most people who have ecchymoses aren't in excruciating pain to the point where you're having to x-ray them. But one really interesting feature about scurvy is the fact that it causes subperiosteal bleeding in the bones. And so as you're trying to rectify this tension between why is this like ecchymosis causing this degree of pain absent compartment syndrome? And one mechanism is to check yourself and say, wait, are you dealing with vasculitis? Which is probably what you should do because the morbidity of that is way higher. But another thing is to emphasize that the bleeding in the skin may represent bleeding somewhere else that is much more painful, which is right there in the bone. And that tends to hurt quite a bit. And I've seen that once or twice now. So when you see this amount of ecchymosis, what you should expect to see is the patient's like, "Hey doc, there's bleeding in my skin. It shouldn't hurt them. We see these kinds of ecchymosis all the time, and it doesn't hurt anybody." So the fact that Sam was so alarmed by his pain to the point where imaging was obtained was an interesting thing, and I think a potential clue to scurvy amongst everything else that we just mentioned. Yeah. So yeah, go ahead, Professor.
Yeah, I was just gonna say it also made me realize like the patient's on Coumadin, and maybe that increases the vulnerability or heightens the perifollicular hematoma that we often associate with scurvy. Like just that additional hit, so like sort of like a two hit, leading to this crazy ECMO. I don't know, was that patient RLR also on a blood thinner that had this
I
sort
don't
of?
think so.
They weren't. Okay.
I
All
don't
right.
think. But I think that's such a great point. Yeah, I mean, I'm sure. Can you imagine if your vessels are fragile from scurvy and you put a warfarin in the mix? Jeez. Yeah. Now watch Sam be like, the vitamin C level was normal and the patient was diagnosed with IgA vasculitis. Sam, check us here, please. Mike to you.
All right. Well, I want to express my appreciation. You, I think like really nicely highlighted the tension that our team was feeling between feeling that he was very nutritionally vulnerable, but feeling that his rash didn't quite look like what we would have expected scurvy to look like. That's exactly, the discussions that we were having with the team. I'll share a little about his clinical course. Um, we had shared with the patient that we were concerned about scurvy before the vitamin C level was back. It takes a few days at our institution. So he like really took that to heart and started ordering orange juice every day. And we gave him vitamin C supplements just sort of empirically. And then his CRP started to rapidly downtrend. Um, and I actually have a third photo because his rash started to resolve very, very quickly. Sarah, do you want to share it or do you want me to? Um, yeah, I can share this. This is what his leg looked like 5 days later. And it became very apparent that it was a perifollicular rash once all the ecchymosis started to resolve.
That
Um,
is so cool.
yeah, it was shocking. And then of course his vitamin C level was undetectable.
Wow, unreal. Oh, tell us how you felt. This is a really, really interesting diagnostic journey to go on. Yeah, what did it feel like in real life?
It was amazing. Because our differential was so broad. We were talking about skin biopsies and warfarin calciphylaxis and endocarditis and all the vasculitides because of his autoimmune history and paraneoplastic vasculitis because of his weird nodule. Like there was so much going on. And then it ended up being such a simple and elegant solution that kind of unified everything. And I really, learned a lot from this case. I didn't know that scurvy can cause such elevated inflammatory markers. That was a really interesting learning point for me. And then I thought it was wonderful we had really good multidisciplinary care for this patient. Rheumatology and heme were involved and talked to us about the subperiosteal bleeding causing his pain. Um, and then just getting the patient involved in his care and willing to sort of think about how he could prevent this from happening again in the future was really interesting. And this is I also want to shout out I think Lucas pretty early on in the chat clocked scurvy and then Lyra immediately got my joke about it being a juicy case.
Prof Rez, I'm really curious to hear what you're taking.
I'm just still caught up on the juicy case. That's like, and I know Yusuf is on this. He submitted something to Najim, and if he had suggested that title for this case, I would say it won't work because there are sharks out there like Kirtan that will tackle it within the first first second. His case. Oh, I'll keep it muted because he probably wants people not to know the diagnosis.
Yeah, my honest take is I think that if you sat in this case and you're like, oh, cool, scurvy can do this, you're getting about 5% of the learning you could get. I think these cases, if you listen to what Sam is showing you, how tense and difficult it is to prove it in real life, and the journey in a case like this really requires you to be open to the possibility that the patient has a vasculitic syndrome. And so I don't know. I think if you see something like this again, exact same presentation, I'd probably say 50-50. And just because this one bent in one way doesn't mean it couldn't have bent the other way. And so, yeah, I think for me, it's a really humble reminder of the many different ways scurvy can show up, but also a humble reminder not to get too caught up in missing what might be a more morbid condition acutely where the kidneys go down and whatnot. So yeah, I really appreciate Sam how you like outlined the tension and how you showed the ANCA serologies and all the rheumatological stuff. But ultimately, a big shout out to our nutritional colleagues who don't get enough love. I think they do so much important work in the hospital, and it was cool that you showed just how pivotal they were in this case. Real treat. Thank you so much. All right, Kevin, I see your video's turned on. You're ready. Take it away, my friend.
Yeah, this has been such a treat, and thank you, Sam, for presenting us this case because I think this is just a lot of learning, and it is also something that teaches us a lot about our patients. So this is why I tried to capture this journey in basically three points. So the first point, obviously, the fact that we've seen the rash and wondered what is the etiology, is that trauma, and also think about the pathomechanisms, why we have such visible purpura. So is it truly an ecchymosis, which is a bleeding into the skin, or is it differentially a purpura, which is a clotting inside the skin? Also remembering that there are cases where the patient may have more severe disease like compartment syndrome, which is important to remember on the clinical context. I think the second and also important point is the vulnerability of the patient. So we are presented with a very rich past medical history, a rich history, medication, family history, and so on. And this just shows us that this is a patient who has several diseases in multi-factors. So based on this, we have to really anchor ourselves in the very highlighted things that we have. So obviously the lupus in the family history, asking ourselves, okay, is there something additionally to the hematuria? Is there proteinuria? If not, perhaps we need to repeat tests in order to understand if there is something going on, considering lupus nephritis, for example. But also the fact that the patient has anemia as well as almost a borderline macrocytosis, thinking of another differential, which is hemolytic anemia, which highlights that the body's heavily connected and we have to think about all these different systems at once. But also revisiting complaints, which means that a microvascular thrombosis may lead to ischemia and pain, while an inflammation of blood vessels doesn't necessarily lead to painful efflorescence. In this case, we go down the line of, okay, this may look like inflammation. The increased INR, obviously, also different etiologies besides drug interactions, which lead us to the point of nutritional deficiencies and may explain other lab tests in this context. And I think also a very important pearl by Rabih today was the fact that if you have inflammatory labs, we just don't necessarily need to dial down on inflammatory causes. If there's something that isn't on a microscopic level visible, we should take a look if there's a non-inflammatory reason for this or a microcellular microscopic cause for this. And finally, the vulnerability of the patient needs to be narrowed down to the actual diagnosis or to the treatment of the patient, which is the most important thing, besides nerding out about vitamin C deficiencies. And that is, first of all, ruling out the several diseases which we talked about before, the vasculitis, for example, small vessel vasculitis, which has a main serological focus, as large and medium vessel vasculitis present differently, not necessarily through serology. And the arc in such cases, as Reza at the beginning pointed out, may be macrovascular thrombi, then later on the small vessel vasculitis, and then reconsidering our DDX, in this case, nutritional deficiencies, towards disease like scurvy. And last but not least, just because somebody may have an ecchymosis, which is at first painful, it may not painful, it may develop into something which is painful, especially if there's bleeding into the bone. So it just shows that such systems are very fragile, but also can be narrowed down. And I think there's a lot of learning today.
Kevin Muller, I can listen to you all day, my friend. It makes me want to fly to where you are and play some soccer and football with you. Kevin, did you know
You
Rob is
are
the
always invited to go watch Bayern Munich, okay?
Oh my gosh, all day. I just want to say your teaching was incredible. Like, what I think makes a teacher such a great teacher is not only the facts they teach, but the story they tell. And my friend, you told a terrific story there with amazing educational nuggets. So I appreciate you. I'm gonna pass the mic to Robbie to close it out. But thank you to you, to Sam, to Sarah, and to Yusuf. And just a quick thing about Yusuf's title was "It's Nuts." Let's see if you guys can determine what the diagnosis is.
No better way to end. Bye, guys.